Bismillahirrahmanirrahim. Our topic today is about ocular trauma. Ocular trauma may be due to mechanical, chemical, or physical injury. Mechanical injury include either blunt trauma, perforating trauma, or trauma associated with intraocular foreign body. Physical injury include either thermal or radiation. We will start with blunt trauma. Blunt trauma, either due to large objects such as football, which when it hits the eye, most of the impact is taken by the orbital margin. But if trauma is due to smaller object like tennis ball, similar to the hand fist, it hits the eye, and the eye itself may take most of the impact and produce most serious complication. Effect of blunt injury on the orbital and ocular structure. We will start with the orbit. It causes either proptosis, which means protrusion of the globe due to orbital hemorrhage, or enophthalmos, which may result from the fracture of the orbital floor, what is called blowout fracture. The floor is the most thin orbital wall, so increase the intraorbital pressure due to the trauma leads to the fracture of these thin orbital walls. Clinical picture of a blowout fracture. Number 1, preorbital emphysema, which means air in the lids and preorbital tissue. It's due to communication between the orbit and the preorbital paranasal sinus. Number 2, diplopia and defective eye movement due to entrapment of the extraocular muscle in the fracture side. Enophthalmos due to the herniation of the preorbital fate into the maxillary sinus. Like this photo, it includes limited elevation of the left eye due to entrapment of the inferior rectus in the orbital floor. What is the management? Oral antibiotic to protect against sinus bacteria and the development of orbital cellulitis, and surgery to correct the enophthalmos, disfiguring enophthalmos, and the entrapment of the extraocular muscle, which is complicated by diplopia. Then trauma may include the eyelid, leading to ecchymosis of the eyelid, what is called traumatic black eye. The treatment in the first 24 hours cold compresses for vasoconstriction to reduce and stop bleeding, followed by hot compresses to help the absorption of the preocular hemorrhage. Then there may be lid laceration, horizontal or vertical. Horizontal one don't gap and produce a small scar. Vertical one gap and need suturing. Traumatic ptosis, either due to mechanical increase the weight of the eyelid from the blood or edema, or paralytic due to injury of the third cranial nerve, which supplies the levator muscle. The conjunctiva. The trauma to the conjunctiva may result in subconjunctival hemorrhage, conjunctival laceration, chemosis. Conjunctival laceration, if large, may need suture. If small, doesn't need suture and may resolve spontaneous and heal spontaneous. Chemosis, which means the edema of the conjunctiva. Then subconjunctival hemorrhage. Subconjunctival hemorrhage means blood under the conjunctiva. It may be due to local ocular trauma or fracture base of the skull, and we should differentiate between both types of subconjunctival hemorrhage. Like the illustrating figure, if it's due to local ocular trauma, it appears immediate after the trauma. The trauma will be to the eye with no proptosis. There is no affection of the level of consciousness. It's usually on the temporal side. It's a shape triangular, the base toward the cornea. We can see the posterior limit, and it's fresh blood, bright red. But if the subconjunctival hemorrhage is due to fracture base of the skull, the onset may be delayed after the trauma. The trauma is to the head with proptosis. There is affection of consciousness level. It may more in the conjunctival fornix. It's also triangular, but the apex toward the cornea and the posterior limit, we can't see the posterior limit. And it's dark red, not fresh blood. Then we will discuss the effect of the trauma, blunt trauma to the cornea. The blunt trauma, if associated with intraocular foreign body, the foreign body should be removed from the surface of the cornea after putting topical anesthesia. Then we treat the abrasion left by the removal of the foreign body, topical antibiotic, atropine, and patching. The trauma may not include foreign body and include only or cause only corneal abrasion, causing severe pain and photophobia. The treatment also topical antibiotic, atropine, and patching. And there is also recurrent corneal erosion. What is recurrent corneal erosion? It's recurrent corneal erosion syndrome. It means that the corneal erosion caused by minor trauma like a scratch with fingernail or paper, and due to imperfect healing of the basement membrane, these corneal erosions can be recurrent. Blood staining of the cornea, it's due to the hyphema, which means blood in the anterior chamber associated with increased intraocular pressure, leading to the pushing of the blood inside the layers of the cornea. Clinically, clearing occurs from the periphery to the center by the phagocytic action, but this clearing process takes a long period, about 1 to 2 years, and may be associated with serious complications. Treatment: immediate control of the intraocular pressure to avoid blood staining of the cornea. Number 2, keratoplasty if blood staining becomes permanent. Also, trauma to the cornea may include corneal edema due to trauma to the endothelium and desmet membrane. Also, it may include perforating trauma and wound, corneal wound, which may need suturing of the corneal wound. Then we will discuss the effect of the blunt trauma on the sclera. It may include wound in the sclera, which is known as scleral rupture. Clinical picture of the scleral rupture: sudden diminution of vision, photophobia, lacrimation, pain, subconjunctival hemorrhage, chemosis of the conjunctiva, shortness of the anterior chamber with or without hyphema, sudden drop of the intraocular pressure, and abnormal size and shape of the pupil. Also, the scleral wound may be associated with uveal prolapse. The treatment includes scleral repair with repositioning of the prolapsed uvea, ciliary body, or choroid, and with abscission of the prolapsed iris to avoid infection. And if the eye is seriously damaged with no perception of light, inoculation should be done to avoid what is called sympathetic ophthalmitis in the other eye. Then we will discuss the effect of the blunt trauma on the anterior chamber. It may include blood in the anterior chamber, what is called hyphema. Hyphema is blood in the anterior chamber, and the source of the blood is ruptured iris blood vessels. The goal of our treatment: number 1, to prevent rebleeding; number 2, to prevent increased intraocular pressure; number 3, to prevent blood staining of the cornea. The first step usually include admission at the hospital to ensure bed rest in semi-sitting position to avoid rebleeding of the injured blood vessels, daily measurement of the intraocular pressure, avoid analgesic which will increase the bleeding like aspirin or NSAID, non-steroidal anti-inflammatory drugs, give topical steroid to control iridocyclitis, give topical anti-glaucoma drugs, eye drops like beta blockers to control intraocular pressure, give antifibrinolytic to avoid rebleeding like oral aminocaproic acid, and if the hyphema is persistent with high intraocular pressure or early blood staining of the cornea, immediate evacuation should be done to avoid the complication of the increased intraocular pressure and the complication of the blood staining of the cornea. Then we will discuss the effect of the plant trauma on the uvea, the iris, and the ciliary body. The iris may include traumatic iritis or iridocyclitis, iris sphincter tears, defect in the constrictor pupillae muscle at the pupillary border. It appears clinically as small V-shaped tears at the pupillary border, like appears in our photo figure. Mediatics should be avoided as they may enlarge the tear. Also, iridodialysis. The trauma may cause iridodialysis, which means separation of the root of the iris from the ciliary body. The pupil appears as D-shaped as illustrated in the figure, and the patient may complain from uniocular diplopia. Also, the trauma may cause complete avulsion of the iris at its root, which is known as traumatic aniridia. And the affection of the iris will lead to the affection of the pupil. The pupil may be damaged by plant trauma and react with the poor reaction to the light, especially if the patient is associated with head injury. It may be a sign of increased intracranial tension. Take care of the pupillary light reflex after the trauma. Also, the trauma may lead to traumatic mydriasis due to the paralysis of the third cranial nerve, which supply the sphincter pupillae muscle, and also the affection of the third cranial nerve will be associated with the paralysis of the accommodation. Or it may the trauma leads to traumatic meiosis due to iridocyclitis. The affection of the ciliary body include either traumatic spasm of accommodation, cyclospasm with temporary myopia, or paralysis of the accommodation due to the affection of the third cranial nerve, or what is called the ciliary body shutdown, which means suppression of the secretion of the aqueous with hypotony, decreased intraocular pressure. And also the trauma may lead to the separation of the longitudinal and circular muscle fibers of the ciliary body, which is known as angle recession, and the affection of the ciliary body will lead to glaucoma, increased intraocular pressure. So ciliary body injury near the angle can lead to what is known as angle recession glaucoma. Also, the trauma may lead to separation of the ciliary body from the scleral sphere, which is known as cyclodialysis. And also we discussed the effect of the plant trauma on the lens. It may lead to lens subluxation and dislocation. It may lead to the traumatic cataract, ossification of the crystalline lens due to the trauma, which may be associated with what is called Vossius ring. What is Vossius ring? It's a circle of iris pigment on the anterior lens capsule due to the imprint of the pupillary border of the iris on the lens. Also, the shape of the traumatic cataract may be posterior cortical cataract, and the most common is what is called sunflower cataract, like the illustrated in the figure. It's a pathognomonic of plant trauma, and it's due to disruption of the lens architecture at the cortical sutures, and also it's known as concussion cataract. The effect of the plant trauma on the posterior segment of the eye, the vitreous may include vitreous hemorrhage, vitreous floaters, vitreous prolapse through wound, vitreous detachment associated with retinal detachment. Plant trauma to the choroid may lead to rupture of the choroid. Plant trauma to the optic nerve may lead to edema of the optic nerve with hypotony, avulsion of the optic nerve with severe affection of the visual acuity, or traumatic optic atrophy. The plant trauma to the retina may be associated to what is called commissio retina. What is the commissio retina? Commissio retina is the edema of the retina. Clinical picture include sudden drop in the visual acuity and is associated with what is called cherry red spot of the foveal. The visual recovery usually occurs spontaneous within a month, but sometimes may be complicated with macular degeneration or macular holes with persistent severe loss of the visual acuity. Also, planned trauma to the retina may include retinal hemorrhage, retinal tears, or retinal detachment. Retinal detachment may be due to rhegmatogenous, due to retinal tear, or exudative due to severe hypotony, due to the ciliary body shutdown, leads to severe hypotony, leads to exudative retinal detachment. Tractional retinal detachment due to vitreous prolapse and its incarceration in the scleral wound leads to traction on the retina and tractional retinal detachment. Then we will discuss the perforating trauma. The perforating trauma may include laceration to the cornea or corneal wound, laceration to the sclera, scleral wound, and it's due to the trauma to the eye with sharp object, nail, knife, and the penetrating injury must be investigated for intraocular foreign body. It may be associated with intraocular foreign body, and the patient and the radiology must be done either X-ray, plain X-ray, or CT orbit to exclude intraocular foreign body. The clinical effect include immediate effect, the wound of the lid, conjunctiva, cornea, or sclera, the prolapse of the uvea with or without vitreous loss, traumatic cataract, and delayed effect, which may include ocular infection, severe infection in the first 24 or 48 hours, or fungal infection, which may be delayed. Also, the perforating trauma may be associated with what is called sympathetic ophthalmitis. Sympathetic ophthalmitis may develop after a long period, up to years, and we will discuss later the sympathetic ophthalmitis, and search for intraocular foreign body. The patient must be investigated to exclude intraocular foreign body. Clinical picture of the globe perforation, like the wound in the sclera. The eye should be gently examined, should be gently handled to avoid the increase or rupture of the partial thickness wound. Immediate patching of the eye, prophylactic antibiotic, and as we said, that radiology must be done to exclude the presence of intraocular pressure, avoid vomiting, give antiemetics to avoid increase intraocular pressure and rupture of the partial thickness wound or enlarging of the wound. Then surgical repair should be done. And if there is no hope of repair or there is no vision in the eye, inoculation should be done to avoid sympathetic ophthalmitis. Delayed chemical effect of the iron from the iron foreign body. It may lead to sclerotic cataract, heterochromia iridis with the ipsilateral iris darker. The affected iris become darker than the other eye. Secondary open-angle glaucoma due to scarring of the trabecular meshwork. Chalcosis pulpoi. Chalcosis pulpoi, if it's pure copper, produce severe inflammation similar to endophthalmitis, and if the copper is in alloys, it produces what is called chalcosis. It's characterized by what is called Kaiser-Fleischer ring. It's the deposition of the copper in the desmoid membrane, leading to a golden brown ring. And also it may lead to what is called sunflower cataract. The management of the intraocular foreign body. The foreign body should be localized either by fundus examination, plain X-ray, or CT scan. Removal of the foreign body. But if it's small and inert, like small pieces of glass, can be left in the eye. Removal of the intraocular foreign body may require porciplan vitrectomy, and removal of the intraocular foreign body using foreign body forceps or with using magnet if it's magnetic foreign body like iron. And if there is any retinal tear, should be sealed with the laser photocoagulation or cryotherapy. And if the eye is badly damaged, inoculation should be done to avoid sympathetic ophthalmitis. What is sympathetic ophthalmitis? It's a bilateral, specific, diffuse inflammation of the entire uvea, usually following perforating trauma to one eye. It's due to allergy to the uveal pigment of the injured eye, which is known as exciting eye of this inflammation. The predisposing factors is perforating wound, especially if it's associated with the uveal prolapse and the incarceration of the tissue in the wound. Its beginning, it's latent and occurs after 1 month or 2 months from 4 to 8 weeks following the eye trauma. The clinical picture include history taking include the history of trauma to one eye and the symptoms of the bilateral iridocyclitis with a variable degree of severity. The symptoms are bilateral, but they start in the exciting eye followed by the other eye. Signs, we will find the signs of bilateral iridocyclitis, we will find the signs of the trauma in the exciting eye, and the earliest sign in the sympathizing eye is aqueous failure. Management. Prevention is very important. If there is hope to restore some vision, any prolapsed tissue should be excised, any foreign body should be removed, the wound should be carefully sutured without tissue incarceration, and close follow-up of both eyes to detect the early signs of inflammation. Treatment include corticosteroids for both eye, atropine, and if the exciting eye is badly damaged and has no hope in vision, inoculation may be the treatment if there is no response to the medical treatment within 2 to 3 weeks to save the sympathizing eye. Then we will discuss the head injury, which is complicated by ocular injury. Immediate effect, contusion of the eye with various effects of blunt or perforating trauma, affection of the visual pathway, papilledema due to increased intracranial tension, diplopia due to affection of the third or fourth or sixth cranial nerve, gaze palsy either horizontal or vertical, horizontal due to frontal lobe hemorrhage, vertical due to brainstem injury, and delayed effect like carotid cavernous fistula, cavernous sinus thrombosis, and orbital cellulitis. Now we finish the effect of the blunt trauma, perforating trauma, intraocular foreign body, and we will discuss chemical injury and physical injury. Chemical injury means exposure of the eye, either accidental or during the work, which is known as occupational injury. Accidental injury including household materials, and occupational injury include strong chemicals as acid, alkali, or war gases. Alkali burn is the most serious chemical burn, is more serious than acid burn. Chemical injury, alkali burn may be produced by potassium hydroxide, sodium hydroxide, or ammonia, which are present in the detergents or fertilizers. Alkali burn are more severe than acid burn due to its rapid penetration, while acid burn will precipitate the tissue proteins which avoid and more penetration and act as a barrier for more penetration. But alkali burn will lead to more rapid penetration through the cornea and the anterior chamber in a few seconds, less than 1 minute. Acid burn include the injury from battery fluid, sulfuric acid, acetic acid. They cause their maximum damage within the first few minutes to hours and less progressive and less penetrating than the alkali. Acid precipitates the tissue proteins, which rapidly set up barriers against deep penetration. Warm gases cause severe keratitis and permanent corneal scar. Lime burn, if is lime burn, it's affection of the eye with calcium oxide, and the lime react with the water found in the tears and the tissue, and it's converted into calcium hydroxide, resulting in severe heat and causing penetration deeply to the ear and more serious injury. The clinical picture, symptoms like the corneal ulcer signs differ according to the exposure. It may include mild to moderate exposure, eyelid edema, chemosis, conjunctival injection, conjunctival abrasion, anterior uveitis, iridocyclitis, or severe exposure. It includes conjunctival and episcleral whitening, coagulative necrosis, corneal edema and ossification with corneoscleral melting, severe iridocyclitis, secondary glaucoma, and posterior segment affection. The emergency treatment of the chemical burn, the most serious step is immediate, copious irrigation of the eye with the antidote or otherwise plain water or saline for at least 1 hour in severe injury and with several liters of water. So the most important step is immediate copious irrigation of the eye with plain water for at least 1 hour with several liters of water. In lime burn, picking off the lime particles must be done before irrigation to avoid more reaction of the calcium oxide with the water to produce calcium hydroxide, which produce excessive heat protection. So pick up the lime particles before irrigation of the eye. Again, irrigation should never be delayed for any reason. It's better to place the eye speculum and topical anesthesia before irrigation, and the lower eye is pulled down and the upper lid is everted to irrigate the conjunctival fornix. It's better to know the specific antidote. If the nature of the chemical is known, the proper first aid is washing the eye by a specific antidote. Alkali burn, its antidote is acid, boric acid or citric acid, which is found in the lemon juice, or acetic acid, which is found in the vinegar. Acid burn, which is found in the sodium bicarbonate, the antidote is found in the sodium bicarbonate. For the lime burn, use concentrated glucose. For iodine burn, use starch suspension or milk. For hair dye burn, use tannic acid. And EDTA is universal antidote. But again, the most serious step is irrigation of the eye with at least plain water with several liters of water for at least 1 hour to remove any effect of the chemical substance on the eye. Then, in mild and moderate exposure, give topical antibiotic, lubricant, and better using eye ointment to prevent symplepharon, atropine, cycloplegic, analgesic, topical steroid to reduce inflammation, but be sure that there is no corneal abrasion as the topical steroid delay wound healing. Give systemic and topical anti-glaucoma to avoid any rise in the intraocular pressure. In the severe exposure, debridement of the necrotic tissue, treat the symplepharon or take precautions to avoid the symplepharon, like putting ointment or putting glass to avoid symplepharon. Topical steroid if the corneal epithelium is intact. Then in the late stage, limbal transplant or conjunctival transplant or penetrating keratoplasty may occur or may be done in severe corneal melting. And finally, we will discuss the effect of the physical injury on the eye. Physical injury include a variety of the electromagnetic radiation, infrared waves, which has a long wavelengths. Infrared waves may cause cataract, and it's seen in glass flowers, and it's prevented by the use of protective goggles. The injury of the longer infrared waves may be seen in the solar rays. Looking directly at the sun may result in a burn of the macula, especially at the time of the solar eclipse. Also, ultraviolet rays, which has shorter wavelengths, exposure to the ultraviolet rays may result in cataract and may result in photophthalmia if there is no protective goggles. So after a little period of 4 to 5 hours, photophthalmia will develop, and it will require patching under the corneal epithelium here. Also, physical injury include microwaves, which may cause cataract. X-ray, the therapeutic, not diagnostic, may cause cataract, and the patient should wear protective goggles during the therapy. Visual display units and television sets, eye strain may occur after several hours of exposure. Thank you.